Today's podcast is brought to you by Audible.com. Get a free audiobook download and 30-day free trial at audibletrial.com/wakeupcallpodcast. Over 180,000 titles to choose from for your iPhone, Android, Kindle, or MP3 player. So go to audibletrial.com/wakeupcallpodcast. That's audibletrial.com/wakeupcallpodcast to get your free audiobook today. Hello and welcome to the Wake Up Call podcast. Today I'm speaking with Dr. Josh Umbehr about the American healthcare system, his direct care medical practice, and how his practice allows for lower costs and higher quality care. Dr. Umbehr operates a concierge direct care family medical practice in Wichita, where he is a family physician. To learn more about his practice and his work, take a look at imdirectcare.com, atlas.md, and the Atlas MD blog at atlas.md/blog. You can also follow his work via the Atlas MD podcast at atlas.md/podcastgen, Gen, as well as atlas.md/Wichita to learn more about his practice in Wichita. You can also find him on Facebook under Atlas MD, all one word, and on Twitter at Atlas MD. For more information, please see the show notes page for this episode at wakeupcallpodcast.com/atlas-md. Josh, welcome to the show.
Thank you very much. Happy to be here.
Thank you so much for joining me. So I like to start out with definitions, and this is going to be no exception here, because I'm guessing that while a lot of people have probably heard the terms direct care and concierge practice, they're probably a little fuzzy on exactly what they are. So what do we mean by direct care? And what do we mean by a concierge practice?
Absolutely. This question comes up a lot for us. And on some level, I would say it's mostly just branding is the key difference. Some doctors prefer to have the more elevated name of concierge medicine. But the overriding term of direct care is the buzzword that's getting the most traction. In general, both are insurance-free practices that typically charge a monthly membership. Then a finer nuance of that would be concierge medicine tends to be the more expensive end, and sometimes will also bill insurance under certain arrangements, whereas direct care is the movement focusing on maximal affordability and does not bill insurance really ever. So direct primary care is the direction I think most doctors want to move in.
Okay, and going over those definitions right there is a pretty good insight into some of how your practice is set up and some of a little of what's different. Before we get into all the differences and similarities, though, between your practice and a typical or more traditional medical practice in the United States, can you give a little more detail about your practice and how it's set up and kind of an overview of what it looks like?
Absolutely. We started just over 6 years ago, September 2010, with the idea that the healthcare system's broken, and not that insurance is bad, but that there's a better way to do it, a more efficient way. And the way that we concluded was a membership model. So we charge $10 per month for children, $50 per month for most adults for unlimited home visits, work visits, office visits, and what we call technology visits. So email, cell phone, texting, Facebook, etc., video chat. Also, to be unique, we don't have any co-pays for anything in the office. And to add value, any procedure we can do in the office is included free of charge. So stitches, biopsies, joint injections, ultrasounds, heart monitors, lung scans, strep throat testing, urine testing, minor surgical procedures, all those are free because the wholesale cost of those, the true cost, is 99% less than what most people expect. But to push the value proposition even further, we do something that most doctors don't, which is wholesale medications, labs, imaging, pathology, etc. So medicine that would be $100 at the pharmacy for migraine, I literally get $5 wholesale. So our patients get it for $5 wholesale. Blood tests that would be $50 or $75, I get for $1.65. So we can use those savings to help justify the value of the monthly membership.
And those savings are just staggering, and I want to return to that subject in a little bit. But let's look at some more of the differences and similarities. You obviously talked about some of the differences between the way your practice is set up and the way a more traditional medical practice is set up. But what are some of the other differences, and what are the similarities?
The similarities would be that in a lot of ways we haven't changed anything. This is still bread and butter, family medicine, pediatrics, internal medicine, everything that you're used to getting from your regular doctor, but just better, easier, less red tape, less hassle. Those are the things that we've changed the most. Whereas your average doctor is really working, their true customer is the insurance company, indirectly through the patient. Because I only get paid if I make the insurance company happy through the billing. So I'm going to spend as much time on my charting to get paid as I did listening to the patient. So depending on the study, Forbes recently had an article that 2/3 of a doctor's day is spent doing their medical charting or insurance paperwork, and only 1/3 of it is actually spent direct face time with the patient. That's ridiculous. They'll have a patient panel of 3,000 to 4,000 and see anywhere from 30 to 50 patients in a day. Versus our model is the average doctor would take a panel of about 600 patients, see about 1% of those per day, so 5 or 6 in the office, and a couple more by phone calls, text messages, emails, etc. But then when you need to see your doctor, you can't. And if you need an hour, you can get an hour with your doctor because the membership model affords that kind of flexibility. So a lot of those are the ways we've changed that. Your average doctor checks out at 5 o'clock to a doctor that you don't know, and they don't know you. In this model, your doctor is available all the time so that when you do need them, you know you're working with the person that you have the most relationship built up with.
Well, the differences are just amazing. They just sound amazing. And it definitely sounds like you're trying to work around sort of the traditional health insurance model and the traditional sort of government role that factors into the American healthcare system. So what you've obviously discussed some of the problems that you're trying to work around and avoid by doing that. But can you talk a little bit more about the problems that you're trying to work around and a little more about why it's so beneficial to do this and how it is even possible?
Absolutely. I think it's important to lay down the foundational principle that we're not anti-government or anti-insurance, but rather pro-efficiency. And, all other things aside, the government just isn't great at purchasing products like this, complex products. And it would do a really good job when it comes to food stamps, but we keep that a very simple cash-based type transaction, no paperwork necessary. Insurance isn't bad. I love my life insurance, and I hope to never talk to my life insurance people. And car and home insurance all make sense because they're actual insurance products. But then we get to healthcare, and we haven't even structured it like it should be. Whereas, the appropriate structure would be insurance for the big stuff, the rare stuff, the expensive stuff, but not for the day-to-day things. A common blood pressure medicine that a big box retailer will sell for 90 days, 90 pills, $10. I get 1,000 pills wholesale for $8. We're pro-efficiency. We don't need insurance now when under the old model, the old understanding, medicines are expensive, so I go the extra mile and insure those. Under the new paradigm, we can show the data that, no, these medicines are very affordable. In part, not to throw any particular retailer under the bus, they haven't competed well, which in economics we'd call, an economic cartel. They just quit fighting each other so hard like they do for milk and meat and toilet paper and every other product on the shelf. Now suddenly it's totally okay to mark up a medicine from $5 to $100. Why? Because the customer doesn't know it. It's getting billed through a copay and a deductible to an insurance, and we're going to just run the price up on that. So like any good economic cartel, we have an incentive to come in and outcompete them and say, well, the true cost of these things are a fraction of that. And if I can provide that at a lower cost, it helps us justify our new fee.
Well, and in addition to being pro-efficiency, as you've suggested already, it sounds like you're very much pro-savings. And of course, we see all sorts of problems with families across the U.S. where they're unable to afford medical care, or they're having to deal with premiums increasing at rapid rates, or where because of the medical needs of their family, it takes a major toll and a major drain financially on their family finances to be able to afford the necessary medical care. So it sounds like someone's less likely to run into those problems if they're a customer at your practice. Can you talk a little bit more about why that is, and just how significant the savings are?
I think the key feature of that inefficient system is that blame is to be rested at the feet of the doctors. And I say that very purposefully because we've tried blaming everyone else, and that hasn't worked. But doctors are the gatekeepers of care. And the insurance company, all they can ever be is a payment model. And I mean that full respect. But my accountant, I'm the payer for the accountant. And I'm not in a position to tell them how to do their business model better because I'm not an accountant. And so a health insurance company, although powerful and big and touching all parts of the system, still can't come to the doctor and understand that those nuances, or that wholesale meds are an option, or labs, or all these other things. So maybe they failed in their group negotiating, but the system failed. So if doctors take that responsibility back, which we struggle with, because in my med school and I believe many others, we were taught specifically that business is bad, economics is bad, that you can't be a caring clinician and a good business person. To which I would say, I don't know how you separate the two. You are paying me to care for your family, and in exchange, you're feeding mine. It's a very personal relationship. And I can carry a supercomputer in my pocket because of good business ethics, of continually creating a better product and a better value. So let's absorb that into the bedside experience and profession, and say that if I take my oath seriously of do no harm, that has to mean do no financial harm. That if I go to a low SES patient who is struggling to keep a job because their migraines are so poorly controlled, and because they can't afford $100 a month if they miss a couple days of work, but now they can afford $50 plus $5 plus unlimited other visits and benefits and cost savings. It's like anything else. That supply and demand curve is incredibly powerful. If physicians take that responsibility, I like to say we didn't change anything. All the tools we had were already on the table. We didn't invent wholesale labs. That was an option. We just went to the lab and asked, hey, can we get a cash discount? 44 states already allow physicians to dispense medicines. How we get our flu shots to give to patients. We just never took it to the next level to say, can I do your daily medicines, because we're so busy trying to bill insurance. And again, to not be anti-insurance, we can take that and go all this value, go to an insurance company, explain to them why this is in their rational self-interest to work in our model and lower insurance premiums. So there was a Fast Company article years back that said how to triple your profits and cut your price in half. To which we communicate that to insurance company CEOs. So you're going to sell your product at a lower price point, but because of the efficiencies we're bringing to the system, take higher, both total and percentage profits. And they've told us their profit margins are 4 times higher with us than with their next best plan, all while decreasing an employer's insurance premiums by 30 to 60% in the first year. We've had employer groups that we've decreased their insurance costs by 75% over 2 or 3 years, so that they're paying less now per employee than they were a few years ago. Radical when you compare that to the skyrocketing costs of premiums for everyone else not benefiting from these efficiencies. So how drastically does that not just change our patients' lives, but their companies' lives, the country, when you could have an economic boom because now we find a way to take money out of a very inefficient system such as health insurance and feed an economy with jobs and healthier people, touching every aspect of the country.
Sure, and correct me if I'm wrong on this, but haven't we seen some of this in the LASIK eye surgery sector as well as the cosmetic surgery sector of medical care, where these areas have been sort of exceptions to the way that this system has operated, and we've seen some of what you're describing already in those areas for years and years.
Absolutely. For every person who says the free market doesn't work, they're quick to free market doesn't work in medicine. They're never the person doing the free market solutions, and B, quick to ignore what is working. And those kind of things are perfect examples anytime where it's, again, a pro-efficiency system, a cash-based system. The patient is dealing directly with the provider of care. No insurance, no middleman, nothing hidden behind red tape and bureaucracy. So that transparency drives competition. I mean, LASIK surgery now, compared to 10 years ago, is a fraction of the cost and several fold better. Eerily similar to every other product in our lives. Netflix, Blockbuster, phones, computers, cloud storage. Amazon Web Services has lowered their price 17 times since they first started, which comes out to almost every 6 months. When has healthcare ever done anything but go up by double digits? But you're talking Amazon Web Services, a highly competitive free market industry, to health insurance, not. So I think this has far-reaching capabilities.
Sure, and I want to return to the subject of savings for a moment. You've discussed some of the statistics related to how significant the savings are at a practice that operates along the model that your practice does versus a more traditional practice. But can you get into that a little more, just how significant these savings are and what some of the cost differences look like?
Well, a average physician billing insurance, according to the national societies, would have between 5 and 7 employees each to have a patient panel of 300 or 3,000. We have one employee, one registered nurse for every 2 physicians. So a 95% decrease in staffing, which gets translated back in efficiency. That savings is forwarded on to the customer. We've had breast cancer chemotherapy medicine for 99% less when you go from worst case scenario to best case scenario, being name brand retail to generic wholesale. It went from over $600 a month to just over $6 a month. That's the kind of impact it can have. I had a person shopping for a medication. They were told by their previous physician to try this name brand medication that is $3,500 a month. Our generic equivalent, $40 a month. When it's their dollars, their livelihood, their work, their future, their retirement, their whatever they could do that money with, they are incredibly quick to make smart decisions. And the generic to name brand equivalent being so close that there's no reason to justify the difference in cost. Arthritis blood work, that would normally be $300 or $400 that we get for $12. For a diabetic that struggles to afford their medication, the blood tests that would normally be $150, we get for $2.25. But their metformin, the medication that we would provide for them for their diabetes, I get 1,000 pills for $14. Wal-Mart is nice enough to sell you 90 pills for $10. Well, we've been to Wal-Mart. We've spoken to their executives at their invitation, and we told them we've out-Wal-Marted Walmart because I know you have to be buying it for less, but I can sell it for less. In a very Costco-esque model, Costco makes 65 to 75% of their profits off their membership. The rest is marginal, and we wanted to create a similarly high-value, low-cost model where once you pass the membership, everything else that we can do, we do for you at the best possible cost. An MRI that would be $2,000, we get for $400. Why? Because cash is king, and we've taken those steps to pre-negotiate those rates to help our patients. And if we can do that, we can justify the value of the whole membership. But there is no cost-value connection to services in the healthcare industry. That's one of the problems. So sutures for stitches, for a cut that you would go to the ER for, $1,500 ballpark easy. Cost me less than $1 to do. So we offer it for free as a service to our patients. But the coffee in my waiting room costs about 60 cents a cup. So if I don't charge you for the 60 cents a cup coffee, why would I charge you for the dollar sutures if I don't have to? We can roll that all up into our value. But again, take all that value and even decrease your insurance costs by up to $1,000 a month. Those are real dollars, real savings that are really happening now that are applicable to the entire country. If you gave 30% of the country a $1,000 raise per month while maintaining the same or better access to health care and health insurance, we would have an economic boom the likes that Reagan would be jealous of.
Right, and it's just incredible, and those really are incredible savings, and it's amazing to hear those statistics laid out. But not only are there incredible savings for the patient, for the customer, but as I teased in my introduction, we also see differences in the quality of care, and we see higher qualities of care being performed in these types of practices. So how does the quality of care differ at the type of practice you're running versus other more traditional types of practices, and why is there that difference in the quality of medical care?
Quality becomes a very interesting topic. It's a hot topic in healthcare now, but kind of always is. Even the father of the quality assurance movement, Dr. Ben, and his name escapes me now, has recently said that he thinks we're doing it wrong. The original goal was to track a handful of metrics that were the most meaningful, the Moneyball stats, and now it's gone so far into becoming a bureaucratic nightmare that now studies are even showing lower quality results from doctors because they're spending so much time adjusting the chart and trying to meet bureaucratic measurements that they're ignoring the patient. So as much as I want to be able to say, yes, we're great, we're wonderful, we do amazing work, which of course is all true, we are always collecting more research to show, it'll take 10 years for direct care lowering blood pressures to show a decrease in stroke risk. But we can lean on other studies that showed free visits for blood pressure management and free blood pressure medicine decreased stroke by 80% over 20 years. Well, that's essentially our model. Every visit is free, that we can utilize technology that insurance wouldn't pay us to use. So your blood pressure cuff is syncing with your medical chart from home to here, alerting your doctor to what your average blood pressures are without you ever coming to the office. And your medication, in this example, to correlate to that study, I get 1,000 of those pills, lisinopril, for $20. So 2 cents per pill long term. I think the pricing almost speaks for itself. If better medication adherence equals good outcomes, better outcomes, well then the better the price, the better the compliance. If cheaper lab testing by 95% means more patients are going to get more health care more often, all at a price neutral or price friendly way. So I think all the data is there, but we're continually, as a movement, trying to collect the large-scale data that will be needed, for today's quality-type studies.
Everybody, stop what you're doing right now and go to audibletrial.com/wakeupcallpodcast. That's because as a listener of the Wake Up Call podcast, you get a free audiobook download from Audible when you sign up for one of their free 30-day trials, regardless of whether you end up getting a paid subscription. You can choose from books we've covered on this show, such as The Primal Prescription by Bob Murphy and Doug McGuff, which is particularly relevant for today's episode, or you can choose from Base Nation by David Vine, or The Problem with Socialism by Tom DiLorenzo, or any of the mysteries, science fiction books, history books, business and entrepreneurship books, or anything else that are among the over 180,000 audiobooks Audible has to offer. To download your free audiobook right now, go to audibletrial.com/wakeupcallpodcast. Again, that's audibletrial.com/wakeupcallpodcast to get your free, did I mention it's free, audiobook right now. All right, so before we draw some additional conclusions about this type of practice, I want to take a step back and look at the American healthcare system more broadly. And I guess with your background in medicine, it would be appropriate to ask you to make a diagnosis on this. So can you offer a diagnosis on where everything went wrong with this system and how it got to the situation it's in today?
Yeah, I think, again, not to beat the drum of doctor responsibility and value too often, but it is that foundational thing. I'm not anti-insurance, very pro-insurance, again, pro-efficiency. And we lost that efficiency at some point where it was a third party paying for the service, and then layers upon layers of complexity just continued to creep in. And that feature creep just meant that now we'll pay you. Before, if you wrote on old triple copy carbon paper, baby delivery, $50, and signed your name to it, that was a receipt. That was the medical chart. That was sufficient for insurance to pay, because we kept the price reasonable because we were going to give that to the patient and they were going to give that to their insurance company. But as soon as we sort of cut the patient out of that transactional process, and they got farther and farther away from it, then the bureaucracy filled up that space. It became more important to keep the masters of insurance and government happy as opposed to the patient. The surgery was a success, but the patient died. Yes, we were checking all the boxes. We were dotting our T's and crossing our I's, but we never turned around and looked at the patient because we tried to do primary care medical home, which showed a 30% higher burnout rate for doctors converting to that model because it was more of a bureaucratic step than it was a clinical step. We never actually focused on the problem. The problem was this efficiency issue. So I'll go when I lecture to students and say, a show of hands, do we have a doctor crisis, a doctor shortage? And they all raise their hands, yes, because like good little Stepford wives, that's what they've been told by their professors. And no, we don't. We have an efficiency issue. I alluded to the Forbes article that said 2/3 of a doctor's day is spent on non-patient tasks. Another article, which is much more conservative, says 1/4 of a doctor's day is spent on that. So we'll take the 1/4 because it's so conservative. If you multiply that 25% of the doctor's day that's essentially wasted across the doctor workforce, that's the equivalent of getting 165,000 full-time physicians back. And they say we're only going to be short 50 to 130,000 physicians by 2025. So we clearly don't have a doctor shortage. We have an efficiency issue. We can't pay for patient care and paperwork. And we've done so much paperwork to the point of ridiculous now that the patient is suddenly getting lost in the whole process. So we pull back, we refocus, and we just say, with all objectivity, what's working and what's not. Do you need me to chart for 15 minutes on a strep throat case? Or would you rather have me available to talk to the depressed patient for 15 minutes more to make sure that they're in good shape and don't spend money down the road because of unmanaged depression? And all these things. Would you rather go get your medicine from Wal-Mart at 100% or $95 markup because no one is competitively holding the pharmacy's feet to the fire? Or would you rather have a patient with migraines or cancer or high blood pressure or diabetes be managed at a fraction of the cost? As long as doctors, surprise, surprise, focus on the patient, everything else falls into place. We appropriately align the incentives instead of a cat and mouse game between insurance and the doctor trying to see who can pay or who can decline payment, and the patient gets left in the middle. Patient is first and foremost. Doctor works very hard with all of their professional skill to bring the best value forward to them. So that means I look for cheaper medical supplies, specialists, best value for the dollar. Cheap isn't always good if it's cheap quality, but best price, best value, because that's what I specialize in. And bring that to the patient, help them out, be available after hours to prevent an ER visit for something that requires a $4 medicine. And engage our patients in a system. And most things are a systems error. And doctors are at the top of this system, if I may be so bold. So we take that position. We put our pride into that. Part of our professional ethos is to bring value to the patient. Then by default, the patient, the physician, the employer, the insurance company, the government, everyone is appropriately aligned, and everybody's happy with the way the incentives flow from each party to the next.
All right, and along the lines of trying to diagnose what's wrong with the system, of course, Obamacare has been in the news a ton lately and for the last several years. So just out of curiosity, how has Obamacare affected your practice? And in case anyone listening to this maybe isn't from the U.S. and they don't know what Obamacare is, can you explain a little bit of what it is as well?
Sure. Obamacare, the Affordable Care Act, instituted in 2010, because the traditional healthcare system was so broken that they were able to, I think, get unprecedented amount of support to create even more government force or involvement, to put it more neutrally, in the healthcare system, and say we're going to mandate all people buy insurance or suffer a penalty, but we're also going to tell the insurance company what they can and can't sell, so that we control costs and services. It didn't work out very well, which was probably predictable, to put it nicely, and now healthcare costs have soared. Just this year alone, many states are seeing a greater than 50% increase in their premiums, but over the last 4 years, prices have doubled or tripled for families per month. So where a family used to pay $400 a month for decent health insurance, now they're paying $1,200 a month. That is a provable, predictable drain on the economy, because that's $800 per month not being spent on goods and services that improve the quality of your life. I'm probably one of the few Republican libertarians who love that, because it's great for my business model. Indirectly. Of course, we don't want patients to suffer, but the system was broken before. Both sides are bad at fixing it. So the Democrats, with the Affordable Care Act, it didn't get any better. It continued to get worse, but got worse faster. But that drove the incentive for patients to finally get past the momentum of the status quo. We needed that shock to our system in a lot of ways to say, okay, this isn't working. And if it's not, how are we going to purchase health care and health insurance differently going forward in a way that's going to be valuable? So at each year, as health insurance got more expensive, and we've never raised our prices in the office, then the delta continually plays in our competitive advantage. Each year at this time, as employers are renegotiating their health insurance and getting sticker shock from the 30, 40, 50% increase in prices, we can go in and say, but there's a better way. But if you think about it a little different, you can come back and lower your premiums. A company, for example, that we worked with in the last few years, we decreased their insurance premiums by 45%, down to $106,000, give or take. At the end of the next year, they got a check for $43,000 of that $106,000 back from their insurance company because of how this insurance model works with direct care. Money not spent gets shared back with the employer, a shared savings program, really basic conceptually. So that was a huge decrease over the 2 or 3 years, and that's more money going back in the employees' pockets. But it had to get that expensive before the employer was like, okay, either we drop employees or we drop insurance. And that pain made them find something better. So that's where it's really benefiting us. While at the same time, all those same things that were stressing out patients and employers was burning out family physicians. Depending on the study, as many as 70% of family physicians are burnt out. They're frustrated. They don't like doing the paperwork. They don't like playing the insurance game. They miss their patients and that interaction with them instead of the computer. So as this model continues to save doctors from that, and you get to come back, work reasonably, make good money, provide great care to great people, this is a solution to that doctor burnout. All movers here in the market are being forced by the system in one way or another to get to a point of willingness to try something new. And that's where direct care is, I think, really going to shine and take off in the next few years. Now, doctors know this is a 6-7-year-old model that's tried, that's true, that's proven, that is now justified by ever-increasing insurance rates. Employers are seeking actively physicians who are doing this model so that they can lower their costs, so they can be competitive with their employees, so they can keep their doors open, so they can give raises or benefits, etc. So I think the system's never quite, darkest before the dawn type analogy here. Now that everyone is frustrated with the system, everyone is going to look for new solutions. And direct care globally is just that unprecedented option. No one else has come along in 20 or 30 years and said, I can lower medication costs by 95% for the vast majority of medications. Elon Musk is doing this with SpaceX. He can send a payload to the space station for 95% less than NASA. Why? Because NASA didn't care about being efficient. They're a government body. They're focused on other things. But he had to make every dollar count. And when we do, it's amazing how much more value we get out and how much the cost goes down. That is why this is the Pandora's box of health reform. Once patients know they can get their meds, their labs for 95% less, once they know they can have unlimited visits, no copays, and free procedures, they'll never go back. Once an employer realizes they can save $2,000 or $3,000 per employee per year on health insurance while getting a better product, they'll never go back. So, in a rough way, the Affordable Care Act is beneficial to the system at large because it's going to encourage the adoption of, I think, cost-effective measures.
Well, let's hope so. But some people seem to think that the Affordable Care Act is going to lead to the adoption of some sort of single-payer or universal healthcare system in the United States. So first, can you explain what a single-payer or universal healthcare system is? And then what are some of the problems that we see with these systems in other countries? And how do those problems compare with the problems in the American healthcare system?
Sure. So there's single-payer, and then there's universal healthcare. Different people have different definitions, but what I would say single-payer is Medicare. The government paying for care, but maybe distributing that out through a variety of private firms, like Blue Cross running Medicare Advantage plans. Medicare is too big for them to run it, so they subcontract it out by state or by region. So single-payer managed at the top, but slightly the illusion of choice because you can pick and choose from maybe 3 or 4 large corporations. Universal healthcare would be a bit more like the Canadian system where the Canadian government controls all of it. So they can control cost. That doesn't mean it doesn't come at a cost. Yes, we say that 9% of the GDP will be spent on healthcare and no more. So if we run out of money in November, I'm sorry, you can't have your surgery in December. We cap that. Obviously, the U.S. doesn't have that problem. We have great health care. We have great outcomes. This is a hotly debated thing, but of course, I'm going to fall on the side where I have my data. Medical bankruptcy. There was a study that half of all bankruptcies are from medical cases, and that was actually not true. It was so poorly done. I believe Harvard came back, redid that study, and showed at most it was 16 to 17%. Infant mortality, they say we would rank very low, like 38th in the world. That study was so poorly done by the WHO, the World Health Organization, that they've never repeated it because they actually just guessed at data for countries that didn't have the information available, or every country uses a different definition of what an infant death is, and that skews the statistics quite a bit. So it's really hard to compare other countries to each other, but I think two maybe useful facts. NIH in England, the governing body there, refuses to allow certain types of birth control into the country because it's considered too expensive. And $20,000 a year for breast cancer treatment means $20,000 that's not being spent on 20 other people. So they refuse that medicine to patients. Or England doesn't even do chickenpox vaccinations because they don't feel that it's cost effective for their limited budget. And that seems bizarre to America. More importantly is Canadian healthcare system, though. There was a lawsuit in 2005 in the province of Alberta. Was a gentleman who had a hip fracture, had to wait for surgery for 2 years, sued the government. The Supreme Court of Alberta concluded that the Canadian system's ban on private medicine was a violation of the Canadian Human Rights Treaty because they said access to a healthcare wait list is not the same as access to healthcare. Anywhere you look, honestly, at other systems, it's falling apart. It's expensive. Medicines are cheaper in Canada because the Canadian government gives $2 billion in prepayments to the drug companies to help them lower their cost. So they still pay. The healthcare system in America is unique amongst all others because our population is unique amongst all others. What we can do, if we're already expensive, let's say by double, well, what if we decrease our red tape, our hassle factor, our bureaucracy? Because medicines are now 95% cheaper. Because I don't need 7 staff per doctor, I need half of a full-time equivalent per physician to provide better care to you. That now your insurance premiums cover more at half the cost of before. So we've gotten here, even though I would still say the data is clear that the American healthcare system has great outcomes, even if they are expensive. We use a lot of healthcare for emergencies, emergency room visits for things that aren't urgent, et cetera. That drives the cost up. That beside the point. We have so much room with the utilization of the direct care model, free market models, to not just bend our cost curve, but destroy it. True creative destruction of our tried and true healthcare system, not because it's bad, but because that's what every industry is challenged to do. They go far past disruptive innovation. Screw that. I don't need a government body to tell me to lower my prices 10%, but we need creative destruction of the standing guard, the old way, the tradition in healthcare, just like Apple. Apple questions everything to the point that they catch the arrows when they kill old technology to bring on new technology. Healthcare system is struggling because we don't have a Jeff Bezos, a Sam Walton, a Steve Jobs, who is so fanatical about quality and cost savings. Jeff Bezos lost $100 million in a battle to sell diapers online because he was committed to bringing a better value. There is no Wal-Mart, Sears Tower, or Stadium because they know they make 3% profit on everything they do. So they have to sell $35 worth of goods to make $1 of profit. Love them or hate them, they are an influential part of our economy because they keep prices low on so much. Who is doing that in healthcare? Who is coming back and saying, I refuse to let your drug prices go up 5% per year or I won't stock it like Walmart does? Who is out there breaking the publishing house stronghold that Jeff Bezos broke because he felt that books should be better and cheaper? But doctors complain more than fix. That's why I put us right at the forefront. If anything's going to change, it's because doctors are in the position to make those changes, and we haven't done it before, but we can do it now.
All right, so before we wrap up, let's very quickly talk about some solutions and advice. So regardless of where someone lives, what would your advice be to the person regarding what they should do as a patient to seek out less expensive and better quality options? And what would your advice be to a doctor who is concerned about the direction things are headed?
As a patient, demand better. Complacency is a poison, and we need patients saying, is this the best price I can get on my medicine? I've heard this, I've shared it, I've liked it on Facebook, I've told my friends about it, I'm asking my doctor about it, But doctors, we're a skittish bunch too. We want to know that if we're doing something, even the doctors who are in a broken system now think they're doing it for the best part of their patients. If their patients go to them and say, Doc, I heard about this model. I want you to go to this model. I encourage you to do this. This is better for me, but it's better for you. I don't want you to be burned out and get divorced and hate your life. Physicians have the highest or the second most highest professional suicide rate. We lose a physician a day to suicide. So we need to do this better for our patients. There's a great book, Start With Why. People buy why you do something, not what you do. Well, we have the best why ever, our patients. So if I were to tell a doctor, why would they change? Because this is better for the people who matter. This is better for your patients, their families, their future. You're helping them get a quality of life several fold better at a fraction of the cost. And this isn't experimental. This is really proving out to be all that it can be. So this is a grassroots movement. But then as patients go back to their employer and they say, I refuse to pay $1,600. There has to be a better way. I heard there's a better way. I want this way. $400 or $500, reasonable fees, but we've got to, the customer has to stop buying healthcare the way they used to, which is if expensive insurance equals good insurance. I get it. It's like doing your taxes. It's no fun to do. So you don't think about healthcare, health insurance. It's complicated. They've made it complicated. There's a lot of small print. So is this a brand name and does it sound expensive so that at least I can feel like I'm getting something good? Because no one wants cheap, quote, bad insurance. But now cheap insurance is great insurance. Let's quit buying it in a broken way and encourage the innovators who are trying to help you and fix it. And if you have expensive meds, if you have expensive labs, if you're tired of copays, if you'd rather text your doctor so you don't have to leave work, demand it. Demand better. Be as aggressive as you would be as any other consumer for the great power that holds.
All right. So if someone wants to learn more about the American healthcare system and about some potential solutions in their own life for their own medical care or that of their families, what would you recommend they take a look at? What resources should they consult?
I think I Am Direct Care is a great resource. DPC Frontier is by Dr. Phil Eskew. That is a great resource. We have our blog, atlas.md. I think one of the best groups is Doctors for Patient Care. They're doing an amazing job. Dr. Lee Gross and several others are trying to work with the Trump transition team to move this forward. If you're in or around Michigan, Senator Patrick Colbeck has probably been the most influential senator in the country on this topic, and he's actively helping patients and systems adopt this. So there's a ton of great resources out there. And for any doctors interested, they can always contact us.
Okay, great. And can you really quickly mention once again the best ways to follow your work and the best ways to learn about your practice?
Absolutely. Patients can go to iamdirectcare.com to find local physicians or DPC Frontier. Physicians will find dpcfrontier.com and our website atlas.md/starter. If they want to download their own free starter kit to launch their own practice, complete with contracts, enrollment forms, vendors, everything free that they need to start a practice. And then, of course, our blog and podcast, they can reach out to us directly at hello@atlas.md.
Okay, great. Well, that sounds like a lot of stuff for people to take a look at to get started. And I'm sure it's going to be very hard to remember all of those resources, so I want to encourage everybody to go take a look at the show notes page for this episode at wakeupcallpodcast.com/atlas-md. And, of course, we'll link to Atlas MD and iamdirectcare.com and DPC Frontier, all of the resources that we've discussed over the course of this interview. And there will also be some links to some other healthcare-related episodes that we've done on the podcast, so that if you want to learn more about the American healthcare system you can listen to those episodes as well. So again, the show notes page for this episode, the place where you'll find all that stuff, is wakeupcallpodcast.com/atlas-md. And I want to encourage everybody while they're on our website to subscribe to the show on iTunes and rate and review the show on iTunes as well, or to subscribe on Stitcher or your preferred podcatcher, as well as to sign up for our email list so that you can make sure to not miss any episodes and catch every single one of them. And Josh, thank you so much for your time today, for being so generous with your time, and thank you so much for discussing your medical practice with me and taking a look at the American healthcare system and some potential solutions for doctors, for patients, and for the system as a whole. So thank you so much for that.
Our pleasure. Thank you.
All right, thank you.
Thank you for listening to this episode of the Wake Up Call podcast.
If you would like to listen to more episodes, please subscribe, rate, and review the show on iTunes, or subscribe on Stitcher, and check out our website at wakeupcallpodcast.com.
There you will find show notes pages and comment sections dedicated to the show. You can also email us at contact@wakeupcallpodcast.com if you're interested in being interviewed for the show or have any other suggestions.
Thank you.